Pain. Week 2. Resources. 1. Van Meter and Hubert. 2023, Chapter 4. Lewis, 2023, Chapter 10. Giddens. Unit D5. Fundamentals of Nursing Pharmacology, a protective phenomenon that is uniquely experienced by each individual, encompasses various dimensions, and is subjectively experienced by individuals. Pain is defined by the individual's perception and is present whenever they acknowledge its existence, is characterized as an unpleasant sensory and emotional encounter linked with real or potential tissue harm, or expressed in relation to such. Injury, dimensions, physiological dimension, and genetic, anatomical, and physical factors influencing pain. Perception, sensory discriminative component, in recognition of the sensation as painful, motivational effective emotional response to the pain experience. Component, behavioral component, observable actions used to express or control pain. Cognitive evaluative component, unbeliefs, attitudes, memories, and meaning attributed to the pain. Sociocultural dimension, factors such as demographics, support systems, social roles past. Pain experiences in culture, dimensions of pain. Fig. 10.2 Nociceptive pain originates when the tissue is injured. Transduction, transmission, perception, modulation, mechanisms of pain transduction. Overview, conversion of mechanical, thermal, or chemical stimuli into neuronal action potentials, occurs primarily at peripheral nerves, notably free nerve endings or peripheral afferent nerves PANs. Noxious stimuli and chemical release. Noxious stimuli include thermal, for example, sunburn, mechanical, for example, surgical incision, or chemical, for example, toxic substances factors. Release of chemicals like histamines, bradykinin, prostaglandins, etc. sensitizes PANs to excitation. Action potential generation. Activation or excitement of PANs triggers the firing of an action potential to the spinal cord. Sodium influx and potassium efflux lead to depolarization of the PAN membrane. Inflammation and sensitization. Inflammation and chemical mediators lower PAN's excitation threshold, increasing transduction likelihood. Sensitization involves chemicals like leukotrienes, prostaglandins, and substance P. Therapeutic approaches. Pharmacological interventions aim to prevent transduction and action potential initiation. NSAIDs and corticosteroids block pain-producing chemicals, interfering with prostaglandin production. Pain transmission process. Overview, transmission to spinal cord. Peripheral nerve fibers, sensations in dermatomes, dorsal horn thalamus and cortex. Pain impulses move from transduction site to brain. It involves transmission to spinal cord, processing in dorsal horn, and onward transmission to thalamus. End cortex. In single nerve cell extends from periphery to dorsal horn without synapses. Action potential travels uninterrupted unless inhibited or disrupted. NA fibers, A alpha, A beta, A delta, and C fibers transmit pain impulses, when A fibers conduct rapidly, while C fibers have slower conduction. When different fibers produce distinct sensations, when A delta fibers produce sharp, localized pain, C fibers cause dull, diffuse sensations, and A alpha and A beta fibers transmit non-painful sensations. Pain nerve fibers entering spinal cord are key to spinal dermatomes. A nociceptive signals processed within dorsal horn of spinal cord involves release of neurotransmitters into synaptic cleft, neurotransmitter effects, various neurotransmitters, for example, aspartate, glutamate, substance P stimulate nearby cells. Others, for example, aminobutyric acid, serotonin, norepinephrine inhibit activation. Neurochemical modulation. Complex neurochemistry can either facilitate or inhibit transmission of noxious stimuli. Exogenous and endogenous opioids play crucial roles by binding to opioid receptors and blocking neurotransmitter release. Particularly substance P nociceptive stimuli move from dorsal horn to third-order neurons. Primary destinations, thalamus and various, brain areas, pathways to the brain, fibers from dorsal horn. Projection cells use pathways like spinothalamic and spinoreticular tracts. Thalamic processing. At specific thalamic nuclei receive nociceptive input from spinal cord. Thalamic projections extend to multiple regions in cerebral cortex. Understanding pain. Acute pain. Sudden onset, severe but short-term. Indicates tissue damage, decreases post-treatment. May be localized or generalized. Triggers physiologic stress response, increased BP, heart rate, cool, pale, moist skin, increased respiratory rate, increased muscle tension. Vomiting may occur. Emotional response, facial verbal expression, high anxiety level, chronic pain, more challenging to treat than acute pain, often perceived as generalized, difficult to pinpoint location. Lack of specific cause complicates management. Fatigue, irritability, depression common. Sleep disturbances, appetite changes, interferes with daily activities, becomes primary focus. Acute pain episodes exacerbate chronic condition. Reduces tolerance to additional injury illness. Referred pain. Fig. 4.3a. Locations of referred pain. B. Proposed mechanism for referred pain. A. From Copstead-Kirkhorn LC, Pathophysiology ed. 4, St. Louis 2009 Mosby. Sensation of pain in a different area from the actual source. Originates deep within organs or muscles. Perceived on the body's surface elsewhere. Example. During a heart attack, pain may be felt in the left neck and arm. Shoulder pain might be mistakenly attributed to diaphragm tension. Challenge. Various sensory fibers converge at the same spinal cord level, making pinpointing the source difficult for the brain. Understanding different types of pain. Central pain, neuropathic pain, ischemic pain, cancer-related pain, caused by dysfunction or damage to the brain or spinal cord. Lesions such as abscess, infarction, tumor, or injury can lead to central pain, can be localized or involve a large area, persistent and irritating, causing significant suffering over time, caused by trauma or disease affecting peripheral nerves, ranges from tingling to burning or severe shooting pain. Movement or hyperexcitable nerves can trigger it. Examples: neuralgias, causalgia. Results from sudden loss of blood flow to an organ or tissues, leads to tissue hypoxia, damage and release of pain-producing substances. Symptoms vary from aching to shooting pain, can be acute or chronic. Atherosclerotic disorders can cause it, especially in lower extremities. Associated with cancer, often chronic. Categories: pain from disease progression, treatment, or coexisting conditions. Pain can be categorized into various types based on its origin, characteristics, and underlying mechanisms. Somatic pain, referred pain, neuropathic pain, breakthrough pain. Definition: somatic pain arises from the activation of pain receptors, nociceptors in the skin, muscles, joints, bones, or connective tissues. Characteristics: it is often well localized and described as a sharp, aching, or throbbing pain. Example: pain from a cut, bruise, or muscle strain is considered somatic pain. Definition: referred pain is felt in an area distant from the actual source of the pain. It occurs when pain signals from one part of the body are perceived in another location. Characteristics: the perceived pain location is often innervated by the same spinal segment as the actual source of the pain. Example: pain in the left arm during a heart attack is an example of referred pain. Definition: neuropathic pain results from damage or dysfunction in the nervous system, leading to abnormal processing of pain signals. Characteristics: it is often described as burning, tingling, shooting, or electric shock-like. It may be chronic and challenging to treat. Example: diabetic neuropathy, sciatic nerve compression, and postherpetic neuralgia are examples of conditions causing neuropathic pain. Definition: breakthrough pain refers to a sudden, intense flare of pain that occurs despite a person's ongoing pain management regimen. Characteristics: it is often rapid in onset and can be severe. It breaks through the background pain that is typically managed with medications. Example: a cancer patient on chronic pain medication may experience breakthrough pain between scheduled doses. Deep somatic pain, central pain, visceral pain, and sympathetically maintained pain are terms used to describe different types of pain based on their origin and characteristics. Let's break down each term. Deep somatic pain, central pain, visceral pain, sympathetically maintained pain. Deep somatic pain originates from structures such as muscles, ligaments, tendons, joints, and bones. This type of pain is often described as aching or throbbing and is generally well localized. Examples include pain from a muscle strain, joint inflammation, or a fracture. Central pain, also known as central sensitization, is a type of pain that originates from the central nervous system, brain, and spinal cord, rather than from peripheral tissues. It is associated with abnormal processing of pain signals in the central nervous system. Conditions such as fibromyalgia, certain types of neuropathic pain, and some spinal cord injuries can lead to central pain. Visceral pain originates from the internal organs viscera, such as the stomach, liver, intestines, or bladder. Visceral pain is often described as a deep, dull, or squeezing sensation, and it may be challenging to localize accurately. Conditions such as appendicitis, kidney stones, or inflammatory bowel diseases can cause visceral pain. Sympathetically maintained pain refers to a type of chronic pain that is thought to be influenced or exacerbated by dysfunction in the sympathetic nervous system. The sympathetic nervous system is a part of the autonomic nervous system that controls involuntary bodily functions. Conditions like complex regional pain syndrome, CRPS, are believed to involve sympathetic nervous system dysfunction, leading to ongoing pain and other symptoms. The dimensions of pain are often categorized into three main components: sensory, discriminative, motivational, affective, cognitive, evaluative, behavioral. This dimension refers to the sensory qualities of pain, including its intensity, location, duration, and quality. It involves the ability to discriminate between different types of stimuli and to localize the sensation of pain. For example, sharp stabbing pain may indicate a different type of injury than a dull throbbing pain. This dimension involves the emotional and motivational aspects of pain. It includes the emotional response to pain, such as fear, anxiety, and distress. The motivational aspect refers to the drive to take action to avoid or alleviate the pain. This dimension reflects the subjective, emotional experience of pain. This dimension involves the cognitive appraisal and interpretation of pain. It includes factors such as the meaning of the pain experience, how it affects one's self-image, and the cognitive evaluation of the pain in terms of its threat and significance. It reflects the individual's thoughts, beliefs, and attitudes toward pain. This dimension refers to the observable behaviors that result from pain. It includes actions taken in response to pain, such as facial expressions, body movements, and avoidance behaviors. Behavioral responses can provide insights into the individual's experience of pain. Serotonin, neurotransmitters play a crucial role in the transmission of signals within the nervous system, including in the context of pain perception. And serotonin is a neurotransmitter that is involved in mood regulation, sleep, and various physiological processes. In the context of pain, serotonin has a modulatory role. It can inhibit pain signals by dampening the activity of pain-transmitting neurons. The medications that increase serotonin levels, such as certain antidepressants, may have analgesic effects by modulating pain perception. Norepinephrine. Norepinephrine is both a neurotransmitter and a hormone that plays a role in the fight or flight response and the regulation of alertness. In the context of pain, norepinephrine can have both analgesic and pronoceptive, promoting pain effects. It can inhibit the transmission of pain signals in some pathways while facilitating them in others. Medications that affect norepinephrine levels, such as certain antidepressants and antiepileptic drugs, may be used for pain management. Substance P. Substance P is a neuropeptide, not a classical neurotransmitter, and it plays a role in transmitting pain signals from the periphery to the central nervous system. Substance P is released in response to tissue injury and inflammation, contributing to the transmission of pain signals. Test inhibition of substance P release or its effects is a target for certain pain medications. Gamma-aminobutyric acid, GABA, and GABA is the main inhibitory neurotransmitter in the central nervous system. In the context of pain, GABAergic signaling helps to dampen or inhibit the transmission of pain signals by reducing the excitability of neurons. Drugs that enhance GABAergic activity, such as benzodiazepines, may have analgesic effects. Endorphins and enkephalins, taught endogenous opioids that inhibit pain transmission by binding to opioid receptors, will introduce analgesic effects and modulate pain perception. Glutamate, primary excitatory neurotransmitter in the central nervous system, involved in transmitting pain signals and sensitizing peripheral nerve endings. It amplifies pain perception and contributes to hyperalgesia. Consequences of unmanaged pain: endocrine, metabolic, cardiovascular, respiratory, genitourinary, gastrointestinal, musculoskeletal, neurological, immunological, groups of pain medications. Fig. 10.7. The analgesic ladder proposed by the World Health Organization. Source: reprinted from Cancer, WHO Analgesic Ladder, WHO copyright, non-opioids. Work through various mechanisms such as reducing inflammation, blocking pain signals, or interfering with the transmission of pain sensations. Non-opioids are commonly used for managing mild to moderate pain and include medications such as acetaminophen, non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen and naproxen, and certain adjuvant medications. Unlike opioids, non-opioids do not carry the same risk of dependence or respiratory depression, making them safer options for certain patients, particularly those with less severe pain or who are at risk for opioid-related adverse effects. Opioids, medications primarily used for the management of moderate to severe pain. These medications exert their effects by binding to opioid receptors located in the central nervous system, CNS, peripheral nervous system, and gastrointestinal tract. Typical adverse effects of opioids encompass constipation, nausea, vomiting, sedation, respiratory depression, and pruritus. Implementation of a bowel regimen should be initiated at the commencement of opioid therapy and maintained for the duration of treatment. Sedation and respiratory depression are among the most prevalent concerns associated with opioid use. In the event of severe respiratory depression, if attempts to arouse the patient, such as calling out and shaking, prove ineffective in reversing drowsiness or enhancing respiratory rate and depth, naloxone, an opioid antagonist, may be administered intravenously or subcutaneously. Coanalgesic or adjuvant drugs are not primarily used for pain relief but can enhance the effectiveness of analgesic therapy when used in combination with opioids or non-opioid pain medications. These drugs serve to supplement or augment the analgesic effects of primary pain medications and can be particularly beneficial in managing certain types of pain, such as neuropathic pain or cancer-related pain. Tricyclic antidepressants enhance the descending inhibitory system and demonstrate efficacy in treating various pain syndromes, particularly those of neuropathic origin. Anticonvulsant medications exert effects on both peripheral nerves and the central nervous system, CNS, proving effective in managing neuropathic pain and serving as a prophylactic treatment for migraine headaches. Corticosteroids, including dexamethasone, Decadron, prednisone, and methylprednisolone medrol, are utilized in the management of acute and chronic cancer-related pain, pain stemming from spinal cord compression, and inflammatory joint pain syndromes. Mild pain can often be managed with non-opioids alone, such as acetaminophen, aspirin, and non-steroidal anti-inflammatory drugs NSAIDs. Mild to moderate pain. An opioid analgesic like codeine or tramadol may be necessary. Severe pain typically requires potent opioids such as morphine or morphine-like agonists. Pain medications approach. Neuropathic pain often requires a combination of co-analgesic and adjuvant drugs such as antidepressants, opioids, or anticonvulsants. NSAIDs, though effective, carry several adverse effects, including increased risk of bleeding, gastrointestinal problems, and renal and central nervous system issues. Notably, NSAIDs other than aspirin have been associated with a heightened risk of cardiovascular events such as heart attack, stroke, and heart failure. Throughout the first postoperative day, it is difficult to balance TC's need for pain medication and depression of her respiratory status. Patient-controlled analgesia (PCA) involves the administration of small doses of analgesic medication at regular intervals to maintain a consistent level of pain relief. Initially, a loading dose is given to elevate the blood concentration of the medication to an effective level. Subsequently, the patient self-administers the medication to sustain the blood concentration within the desired therapeutic range according to their pain perception. Adjustments to the type of medication, dosage, and timing may be necessary to optimize effectiveness. Viewing PCA history and monitor trending with Alaris system www.bd.com/n-us/videos/viewing-pca-history-and-monitor-trending-with-Alaris-system. Includes details such as the total amount of medication administered, the number of bolus doses delivered, any incidence of breakthrough pain, the timing of each dose. By reviewing this information, can assess the ineffectiveness of the pain management. Nurse conducts ongoing assessments of the patient's pain status, vital signs, level of sedation, respiratory status. Collaborates with the healthcare team to make necessary adjustments to the PCA regimen. May involve titrating the medication dose, changing the type of analgesic used, or implementing additional pain management strategies. Anesthesia, types and uses. Local anesthesia injected or applied topically to skin or mucous membranes. Blocks pain stimuli transmission from specific small area. Example, lidocaine for tooth extraction, skin lesion removal, or painful diagnostic. Procedures. General anesthesia intravenous, for example, propofol, or inhalation, for example, sevoflurane. Affects brain, causing partial or total loss of consciousness. Used in general surgeries to eliminate pain and awareness when combined with analgesic. Relative or AT allows response to questions or commands. Enables surgeon to assess progress through patient's response. Example, diazepam or droperidol. Neuroleptin anesthesia. Spinal anesthesia and local anesthetic injected into subarachnoid or epidural space around lower spinal cord. Blocks sensation at and below level of injection. Used in lower body surgeries and labor delivery. Some practice concept questions on readings. 1, 2, 3, let's go. Ready to start a case study. Scenario. TC is a 49-year-old woman who 3 weeks ago underwent a vaginal hysterectomy and right salpingoophorectomy for abdominal pain and endometriosis. Postoperatively, she experienced an intra-abdominal hemorrhage, requiring transfusion with 3 units of packed red blood cells (RBCS). After discharge, she continued to have abdominal pain, chills, and fever. She was readmitted twice, first for treatment of postoperative infection and second for evacuation of a pelvic hematoma. Despite treatment, TC continued to have abdominal pain, chills, fever, and nausea, and vomiting. TC has now been admitted to your unit from the Post-Anesthesia Care Unit PACU after an exploratory laparotomy. Vital signs VSs are 130/70ths 94, 16 37.8 degrees Celsius, Respirations are shallow, and her SpO2 is 93% with oxygen at 2 Albanian leks by nasal cannula. She is easily aroused and oriented to place and person. She dozes between verbal requests. She has a low midline abdominal dressing that is dry and intact, and a Jackson-Pratt drain that is fully compressed and contains a scant amount of bright red blood. Her fully to down drain has clear yellow urine. She is receiving an IV of 1000 ml D5.45 ons at 100 ml HR in her left forearm with no swelling or redness. TC is receiving IV morphine sulfate for pain control through a patient-controlled analgesia PCA pump. The settings are dose 2 milligrams, lockout interval 20 minutes, 4-hour maximum dose of 30 milligrams. When aroused, she states that her pain is an 8 on a scale of 1 to 10. What concerns you most right now about TC and why? Identify factors that are affecting TC's respiratory status postoperatively. Identify factors that are affecting TC's respiratory status now. TC is a 49-year-old woman who 3 weeks ago underwent a vaginal hysterectomy and right salpingoophorectomy for abdominal pain and endometriosis. Postoperatively, she experienced an intra-abdominal hemorrhage requiring transfusion with 3 units of packed red blood cells. RBCs. After discharge, she continued to have abdominal pain, chills, and fever. She was readmitted twice, first for treatment of postoperative infection and second for evacuation of a pelvic hematoma. Despite treatment, TC continued to have abdominal pain, chills, fever, and nausea and vomiting. TC has now been admitted to your unit from the Post-Anesthesia Care Unit, PACU, after an exploratory laparotomy. Vital signs VSAs are 130/70ths, 94/16, 38.1 degrees Celsius. Respirations are shallow, and her SpO2 is 93% with oxygen at 2 Albanian leks by nasal cannula. She is easily aroused and oriented to place and person. She dozes between verbal requests. She has a low midline abdominal dressing that is dry and intact and a Jackson-Pratt drain that is fully compressed and contains a scant amount of bright red blood. Her fully to down drain has clear yellow urine. She is receiving an IV of 1000 ml D5.45 ons at 100 ml HR in her left forearm with no swelling or redness. TC is receiving 4 morphine sulfate for pain control through a patient-controlled analgesia PCA pump. The settings are dose 2 milligrams, lockout interval 20 minutes, 4-hour maximum dose of 30 milligrams. When aroused, she states that her pain is an 8 on a scale of 1 to 10. What interventions do you need to implement to promote TC's respiratory status? Throughout the first postoperative day, it is difficult to balance TC's need for pain medication and depression of her respiratory status. Patient-controlled analgesia PCA involves the administration of small doses of analgesic medication at regular intervals to maintain a consistent level of pain relief. Initially, a loading dose is given to elevate the blood concentration of the medication to an effective level. Subsequently, the patient self-administers the medication to sustain the blood concentration within the desired therapeutic range according to their pain perception. Adjustments to the type of medication, dosage, and timing may be necessary to optimize effectiveness. Viewing PCA history and monitor trending with Alaris System WW includes details such as the total amount of medication administered, the number of bolus doses delivered, any incidence of breakthrough pain, the timing of each dose. By reviewing this information, can assess the ineffectiveness of the pain management. Nurse conducts ongoing assessments of the patient's pain status, vital signs, level of sedation, respiratory status. Collaborates with the healthcare team to make necessary adjustments to the PCA regimen. May involve titrating the medication dose, changing the type of analgesic used, or implementing additional pain management strategies. During the past 24 hours, TC had 122 PCA demands and 31.5 doses delivered. How many total milligrams of morphine sulfate did she receive? The settings are dose, 2 milligrams lockout interval, 20 minutes, 4 hour, maximum dose of 30 milligrams. During the past 24 hours, TC had 122 PCA demands and 31.5 doses delivered. What is your analysis of this information? What will you do? How do you best evaluate the effectiveness of the PCA therapy? The healthcare provider plans to titrate a patient-controlled analgesia PCA machine to provide pain relief for a patient with acute surgical pain who has never received opioids in the past. Which of the following nursing actions regarding opioid administration are appropriate at this time? Select all that apply. Which characteristic is a side effect of opioid pain medications? Select all that apply. Case scenario completed. The physician adjusts TC's pain management regimen. By the end of the second postoperative day, her pain is better controlled. Week 3 synchronous, focus, resources, immunity, and inflammation. Van Meter and Hubert, 2023, Chapter 5 and 7. Lewis, 2023, Chapter 141,617, 18, 67. Pharmacology Notes, Unit F. Fundamentals of Nursing Pharmacology, 1. Antimicrobials, 2. Autonomic Nervous System, Regulation.